Thank you. Oh, it's on. Perfect. So as you mentioned, my name is Michaela Schmidt. This is Alicia Alto and Vivian. And we are part of the University of Minnesota Rochester's Institute for Healthcare Improvement. And tonight we're going to be talking on the basis of improving patient and provider experience through investigation, a collaboration between University of Minnesota Rochester and Mayo Clinic. So just a brief overview of what we're going to be going through this evening. So we're going to talk about what IHI is, Institute of Healthcare Improvement, and then the model that they use for their projects. And then we're going to just dive in on our projects that we've done in the past, just going over what we found in those and how we hope to better them in the future, and then what we're going to plan on doing in the future as well for the organization. So the Institute for Healthcare Improvement is called IHI as well. It's an international nonprofit organization that you can find a lot of physicians, nurses, any type of medical staff that cares about quality improvement and is active in it. They'll be a part of this organization. It was founded in 1991, and their vision is that everyone has the best care and health possible. And then their mission is to improve health and healthcare worldwide. So as a university, we are a chapter of the larger organization, which is pretty cool. We're student-led and university recognized as an organization on campus. And it's kind of cool because our UMR chapter was founded in 2009, which is right around when the university started. So we've been around for a while. And we work with Dr. John Bachman, who is a family physician at Mayo Clinic's Baldwin building. So most of our research is going on in the family department at Mayo. And in addition, Dr. Rachel Olson works for the university as a professor, and she is our faculty advisor here. So it's kind of a cool approach. Mayo benefits as we're sending students in to provide them with an outside perspective on their processes and what they do every day. And we frequently will talk about how, you get into your routine and you don't realize that, why do I keep doing this over and over again? Why don't I just do something different? And so it's nice to have a student's perspective. So in that way, Mayo benefits. We provide them with the data and the data collection. And as a result, our students also benefit. So our students are able to get patient shadowing in, be in the healthcare setting, which is really important and kind of hard for students to do as undergraduates with HIPAA and all that. So it's a win-win situation for both. And so we have this short little video that I'm going to play, and it's about why quality improvement is important. Just a cute little cartoon one. So we'll play that.
So I suppose the first question is, why should you or I care about quality improvement? I mean, to be honest, it sounds a bit boring. A CEO would have on her or his corporate objectives. But actually, if you dig a little deeper, it's pretty cool. Maybe more philosophy or an attitude about how to make something better. And now that I think about it, it's really the attitude I'm looking for in my patients. The ability and desire to tweak their habits, seeing if this change improves their life, and if it does, to try and make it standard practice. You see, for my patients to make these changes requires skills, but it's also an outlook. The humility and self-awareness to say, I've got room for improvement. The ability to gather better approaches, try them on and see if they work, and then adapt them until they do. Well, if my patients can do that, I think they deserve the same from us in the healthcare business. So I suppose the next question is, if we have the attitude, how do we actually improve? How do we use QI to make care better?
All right, and so, let's see. Okay, so IHI's answer to how we make quality improvement better is through their model for improvement called the Plan, Do, Study, Act, or PDSA cycle. And so, and this is important. It's important to have kind of a systematic way of determining whether or not a change leads to improvement. And so before enacting the PDSA cycle, you first kind of define the aims of what you're trying to accomplish. And then from there, determine the measures of how you will know whether or not something will result in improvement. And then from there you can go into the plan cycle. So this is, or the plan step. And so this is when you kind of plan your data collection and kind of predict what you think will happen and why. So for example, one way we used this step last year was when so I don't know if you've ever experienced, if you're trying to make a phone appointment, like a doctor's appointment over the phone, and you either are waiting for a long time or you're transferred to many different departments. So we were wondering why this happened, or like why this was happening, or what possible ways we could use to solve this problem. And so we defined our aims, and then for our plan, we created kind of a survey. So we came up with various questions to ask patients on their experience. And then we plan to kind of combine it with our patient shadowing project, which we'll talk a little bit more about later. And so that was our plan. And so after that, we moved on to the next step, which is the do step. And so this is when you test the changes. You start on a small scale and then slowly work your way up as you go. And so this is really important because it's good to have an appropriate scope for these projects because first of all, people are very resistant to change. And second of all, there are a lot of variables that can affect the outcome of a test. And so it's really important to kind of start small and work your way up. And so for us, this was just starting off by asking a few patients their phone experiences by making appointments over the phone. And so from there, we moved on to the study step, which is when you kind of look over your data and analyze it and kind of reflect on everything you've done. And so when we looked at the data we received from the test, we found that a lot of the patients either didn't remember their experience over the phone or they had already made an appointment at their previous appointment. And so we didn't end up having as much data as we thought as we would have to work with. And so we kind of moved on to the act step. So this is kind of when you adjust your parameters and make modifications to move forward. And so after kind of looking over our data, we just thought about, would it really be worth it to put more time and effort into this study if it looks like a lot of the patients didn't have a lot of responses for it. And so, well, ultimately we decided to kind of put our effort into other things, and then if we do have the time to kind of change and modify the plan, that's something we could work on at a later time. So that is just kind of an example of how the PDSA cycle can be used to determine whether or not a test can be used for improvement and is effective.
All right. Due to the nature and mission of our group, we required all of our members, including ourselves, to complete a basic curriculum through IHI's online portal, and that was called Open School. So Open School offered us a variety of courses, but the two that we required for our certifications were improvement capability and patient safety. So these courses covered the model of improvement that Alicia just mentioned, and other topics such as how malpractice occurs. And so the two highlighted ones there are the courses that we were required to take for our certification. And through viewing many videos, case studies, and research in these courses, we were able to learn more about how to specifically approach quality improvement in the patient care setting. And we also learned about how usually when malpractice occurs, it's not the fault of just one single individual. Of course, there's always going to be human errors, and those factors of those are actually covered in our patient safety course. But the true fault is usually in a system that fails to account for or prepare for the possibility of these errors, and that's when the system fails to uphold patient safety. So by completing Open School, being tested on all these topics, our members were then able to be more competent to participate in our projects.
So our first project has been going on for at least a few semesters. I would say probably 2 academic years at least. But you know, you never can have enough sample sizes. So the purpose of this patient shadowing is to determine the efficacy of patients' time spent in the clinic in conjunction with patient satisfaction, and then from there determine if a change in appointment time would change patient satisfaction. As we all know, healthcare revolves around money in many aspects, and appointment times always could be shortened to fit more in a day. So we were trying to see if we could get support to either shorten or extend appointment times. So it's kind of hard to see, but these are a little form that where students went in and did. So after completing the open school coursework, students are eligible to go into the clinic setting and do some of the projects. So last semester we had 2 semesters ago, we had students go in, they would have this form on a clipboard, they would go up to a patient in the waiting room and they would say, you know, I'm from IHI, this is what we're doing, would it be okay if I sat with you for the duration of your appointment? And most patients agreed to do that, which is really cool for our students because not only did they get to collect data, but they also got to sit in on an appointment and get some shadowing time as well. So the form goes on to say, you know, have you been seen at Mayo Clinic in the past 4 weeks? Are you meeting with your own provider today? Is your appointment for a previously seen problem, etc.? And then the most important part of it is the time study. So the patient or the student would record when the patient got called to the room, when the nurse left the room, when the physician entered the room, and then so forth until the patient left the floor. And from there, we were able to collaborate the data and the times, and based on our shadowing appointments, this is what we got. So an average appointment time was 54 minutes, so that was from the time that they were called back to the room until they left the floor. So the time they met with the physician and the time that they met with the nurse as well, and the time waiting. So as you can see, it's very interesting. 40% of the time was spent with the provider. And when I say provider, I mean it could have been an MD, a PA, or an NP. And then the 35% of the time is spent with the nurse, and then about 25% of the time was spent waiting alone. And as I said previously, we started the time when they got called to the room. So this time spent waiting alone was spent waiting back in the clinical room, not in the waiting room. So then we kind of took a little different approach on the data that we had, and we looked at the average duration of an appointment based on provider type. This graph is showing the entire appointment time, so from when the patient was called to the room to the time that they left the floor. And then the next one is showing the average time spent with the provider. And you can see those standard error bars. There was a wide variety of times depending on the patient and depending on the provider. But as you can see, the nurse practitioner and physician's assistants tend to spend more time with the patient than an MD, which we thought was really interesting. And then from there, we would, at the end of the appointment, we would ask the patient, you know, how much do you think your time was valued during your appointment? And we had really good results. Even the appointment that was 98 minutes long and they spent so many minutes waiting, they still perceived that time as valuable. But as you can see in this one, the MD has a lower perceived value of time than the nurse practitioner and physician's assistant, which is interesting, and we are looking to go further into why this is. But as a result, we concluded that time scheduled per appointment should not be decreased. We work with Dr. John Bachman and Mayo had been pushing for reduce in scheduled appointment times. So I believe it was from 20 minutes to 15 minutes, if I recall correctly. And we were finding that the average time spent with a provider was 20 minutes, so decreasing it would not be beneficial at all. So we have some evidence to support that, but as always, we're gathering more. And as we all know, timeliness is important for both physicians and patients. And then for 2017, we're going to continue doing some patient shadowing, trying to increase our sample size and increase the types of providers that are being shadowed. And we also are going to work on changing it up and have the patients record their time instead of having students there. It gets a little tricky with students and patients, the times aligning and whatnot. So from there, we're hoping to get a bigger sample size and see what we can do.
All right, and so a second project. So this is a project was in a span of one semester last spring, and so it was for shadowing nurse prescription refill staff. And so this was kind of interesting because it offered kind of a new side of healthcare that you don't normally see or think of when it comes to family medicine. So if you're in the Baldwin building in the family medicine area, to get to your appointment, usually walk straight past to the reception desks. And on the left, there's a kind of a closed off area with a bunch of cubicles and employees who are the prescription refill staff. And so they sit there and, as they get requests for prescription refills, they refill those throughout the day. And so there's definitely a lot of different components that go into a hospital and making it work. And so this was just one of those areas. And so what we wanted to do was to shadow the prescription refill staff to outline a workflow of the process, because there are a lot of different people and kind of tasks involved in that. And then we also wanted to identify any inefficiencies, if there were any, to make the process easier if possible. And so what we did is that we would observe the staff, and then kind of take notes on what they were doing. We'd ask them questions like, why are you doing it this way? Are there any other ways that you could think of that would be more efficient? Are there any problems in the system that you see? And it was kind of interesting because recently they updated the patient requests to an electronic format, and so where they used to have to deal with papers, and so there's still a little bit of adjustment going on with that. And so this was the workflow we ultimately came up with. You probably can't read it very well, but kind of the main takeaway is that there are a lot of steps involved and a lot of processes, and just a lot of collaboration that exists between both the provider and the nurse and the refill staff and the patient and the pharmacy. And there's just, a lot of different steps. And so for our results, we took a percentage of where the requests were coming from. And so a little over half were coming from the pharmacy themselves. And then 34% came from a supermarket, whether it be Target or Cub or something like that. And then 11% were patients or other, so whether that be patients calling in or personally requesting medication. And so then our ultimate conclusions were, we kind of had two main conclusions. So the first one just had to do with miscommunication. So there were different difficulties, whether it be from the pharmacy, and if they send multiple requests of the same medication, or if they continue to send requests even when the patient has stopped taking the medication. And then patients also tend to lose the written prescriptions, which kind of shows how effective maybe an electronic system is. And then secondly, a lot of the efficiencies that we saw were in the technology as well. So you would see the prescription refill staff, they would frequently be switching between different programs. which looked very confusing as you're trying to kind of work with the same patient, but you still have to flip between different screens and different programs. And then additionally, it was inconvenient when checking controlled substance agreements. So for certain prescription refills, they need a certain agreement, but it's not just an easy step to check whether or not the patient has the agreement. They have to go on a different program to check that. And so it's a little bit inefficient in that area as well.
All right. And our third and final project that we're going to be discussing here is our longest one. It spanned over the course of a year. So I hope you like my voice because I'll be talking a lot about it. It was in conjunction with the Wellness Champion program at the Mayo Clinic. And the Wellness Champion program is one that spans all of the Mayo Clinic campuses. It has about 400 employees working it. And usually one wellness champion is assigned to each department at the Mayo Clinic. And even though they're kind of spread out, they all have the same goals, which is to promote more participation of Mayo employees in healthy living programs, such as the one offered at the Dulk here in town, to basically introduce or improve lifestyle habits, and then lastly, to contribute to an improved work atmosphere. So back in April of 2015, I had the amazing opportunity to lead a small group of RIHI students in a collaboration with one WC, Wellness Champion in particular, and her name was Elizabeth Huffman, and she had reached out to Dr. Bachman at the Baldwin Building's Family Medicine Department after she heard about our work with incentivizing the distribution of patient information and pamphlets. So she'd heard about that, reached out to him, and she wanted us to basically come in and offer a new set of eyes and help her become a more effective wellness champion for her colleagues. Because what was happening was that she was in a really stressful position. Employee participation was very low for these program initiatives. They weren't seeing really anybody using any of the existing implementations. And so we had to kind of figure out how to introduce new ideas and ways that would be more interesting. These topics could be more interesting for the Mayo employees there. So over the course of a year, the role of Wellness Champion would rotate to different Mayo employees, but my group still maintained the original plan that we had with Elizabeth, which was to focus on developing a culture of health awareness for their workplace. And so what is a culture of health? We defined it as one that focuses on the promotion of improving quality of life, and that was through focusing on prevention, diet, exercise, mental wellness. So in order to promote this concept, we would expand on the existing programs that family medicine already had in place, as well as introduce new implementations that were still within our resources and our limitations as undergraduate students. So my group and the WC there started with these three broad questions on the screen here that would help us focus on our specific aims for this project. And I felt that it was important for us coming in as new members of this environment to understand what we were trying to accomplish as well as why it needed to be done. And the first question, why are healthcare employees so unhealthy? And through pretty extensive research, looking at scientific literature, we found that ironically the people who provide us with healthcare are some of the most unhealthiest employees of the job market. They have high rates, much higher rates of chronic conditions that range from diabetes to depression to spine disorders, and they mostly stem from the fact that these workers have long demanding shifts, usually in a sedentary position, and that doesn't allow them to really participate in physical activity or seek out healthier meals within the workday. So as a result, healthcare employees, they have negative impacts to their cardiovascular system, their metabolism, their ability to be physiologically resourceful, we found, and even their coping skills. And I can't forget to mention just the cherry on top, the mental stress from their occupational demands that are in a hospital setting. we're in Med City. I'm sure you at least know somebody at Mayo Clinic who talks about how demanding the job is. And so that's terrible to know, but you may be wondering why it was so necessary for us to work alongside the Mayo Clinic organization itself to improve the wellness of their employees. Usually when it comes to personal developments, things like achieving a healthier lifestyle, I think our culture really pushes for independent improvements, things you could do on your own. But we felt that the need for wellness champions was really, really crucial in the workplace because it goes without saying, but healthcare employees, if they're healthy themselves, they would be able to provide better care to their patients. And so having healthy employees translates to less need for their staff to ask for medical leave, and then that leaves that means that there are less departments who are understaffed, and then there's also just better overall occupational performance from providers, nurses, secretaries, etc. So now that we've proven that a healthy workforce is a more productive one, where else to promote a healthier lifestyle than within the workplace, where they spend almost more than 40 hours a week there. And the very last question that we had, which was really important, probably the most important to us, was how can wellness champions be more effective, and how can we as IHI students help them achieve that goal? And we focus on 3 main wellness concepts that I'll dive into a bit before I explain how we promoted them. So the first was healthy eating. How could we promote healthy eating to Mayo employees who eat 1/3 of their meals at work? And we had to first define what is a healthy meal. Is it low fat? Is it low carb? Is it organic? And we went through a lot of articles, and while we were going through literature, we found that we actually, as students, we were almost falling victim to kind of health fads, the things that you see on Facebook that are kind of gimmicky and tell you to eat 1 grapefruit in the morning and then snack on kale for the rest of the day. And we knew that would not fly with Mayo employees. It wouldn't fly with anyone. But that wasn't really our goal. Our goal wasn't to slim down the Mayo employees. Our goal was to energize them and to offer meals that would combat conditions like obesity and diabetes and high cholesterol. So we established recipes that we felt people would be more open to, since dietary habits are really, really difficult to change. And I'm speaking from personal experience. Like, I love fast food. So to change my routine from going through the drive-thru in 2 minutes to spending hours each week prepping meals, that was excruciating. That was so painful. And it would have been much harder to complete if I were making meals that I didn't even like, that I wouldn't even eat on a normal basis. So it never would have worked. And our group and the WC chose recipes that were easy to prep, that were easy to cook, that used seasonal, cheaper, accessible ingredients, things that you would already have in your pantry and your fridge, and that could even be considered alternatives to things that we already love but are really bad for us. And next was fitness. So we wanted to motivate more employees to participate in physical activity, both inside the workplace and outside of the workplace. It was important to consider the workload and accessible resources that are allowed to our healthcare workers. We found that many of them didn't have a membership to the DALC, even though the DALC is offered to all Mayo employees. And that meant that we would want to focus on exercises that would be just as good as a gym workout, but that wouldn't require all of those equipment, things that they could do at home, things, yes? Oh, I'm sorry, that's the Dan Abraham Healthy Living Center. And that's actually right in town. It's a beautiful facility. They offer classes, they have a lot of equipment, they have a pool, and so that their membership is offered to Mayo employees. The more you go, the less it would cost per month. And so they are trying to incentivize their employees to utilize that facility and those programs. But we found through personal interviews that actually most of them did not utilize the DALC, and most of them didn't have gym memberships elsewhere either. So it goes without saying, if they weren't very motivated to participate in fitness activities. And so we also had to take into consideration the seasons. and Minnesota's very harsh weather, as you probably experienced yesterday and today. So we wanted to offer exercises and ideas that would be realistic in our given environment. Ergonomics was also a huge central part of developing our fitness concept. Since as I mentioned earlier, they spend a lot of time sitting in front of a screen, and that could be severely detrimental to one's health. So we wanted to offer exercises that could be done right there in the family medicine department in their seats at work. And that would be beneficial to both getting the employees in the habit of physical activity as well as motivating them to be more active while they're on the clock at work. And our last focus concept was with mental health. So usually when you think of a healthy life structure, the main pillars are diet and exercise. But honestly, I think that mental health should be the foundation of all of it, because having anxiety or stress or depression, those things could be crippling to one's personal life choices. And how many times have you heard the term comfort food? And usually comfort food isn't a salad or zucchini noodles. Usually it's something much unhealthier. And when you're lacking sleep or coming home from a really difficult day at work, the last thing you want to do is go to the gym or put out your yoga mat at home. And so by prioritizing mental health for the workers, that was really central to our overall culture of health awareness that we wanted to develop for the family medicine department with the Wellness Champion. And so we sought to reduce work-related stress and push employees to consider how improving their mental wellness would also benefit their job performance and their interactions with their patients. And as you see here, Dwight, hopefully by prioritizing mental health, you can go from that to that. And so we had 2 ways that we introduced our implementations for improving diet, exercise, and mental health. The first was through electronic newsletters, which we titled Work for Wellness. And this was sent to every employee in the Baldwin building every month through email. So it was easily accessible wherever they went. They could take it home with them. They could print it out. And we would include a recipe for an entree, a recipe for a dessert, offer exercises and ergonomic techniques. And as you can see here on the left, our first drafts were pretty elementary, pretty simple. And over the course of the year, we were able to get better programs, better resources, and make it look more aesthetically pleasing, look more professional, and hopefully more attention-grabbing for the main employees that we were trying to reach. And to determine, next slide, please. To determine whether or not people were actually reading these newsletters and as well as how they felt about them, my group and the WC issued quarterly surveys online. And so we asked questions about our recipes, we asked questions about our fitness exercises that we offered in the newsletters, and we also asked questions about the mental health initiatives that we placed into the newsletters. And here's one response to the survey question, which was, how likely are you to try one of the recipes offered in the Work for Wellness newsletters? And from 40 responses in this survey in particular, we saw that over half of the employees, 53%, said that they would be likely to try one of the recipes. About 29% said that they would absolutely not try it. They didn't like it. Or 18% said they were unsure, so they were still undecided. And so that told us that at least half of the people that we were trying to reach, or at least the half that took the survey, were interested, were paying attention to the surveys, and we were structuring them in a way that was appealing to them. And then next, here are 2 questions that we asked about fitness. The first was similar to the last one. So that was, how likely are you to try one of the exercises that we offered in the newsletter? And we were a bit disappointed with these results because about 32% of people said that they were likely to try one of the exercises. Almost half, so 47%, said that they would not try the exercises. And 21% said that they were still undetermined, still on the fence. And so that told us that either the exercises that we were offering didn't fit what they like to do for physical activity, or that we just weren't doing a very stellar job in motivating them for physical activity. And so we contributed that to kind of the law of motion, where like once you stop in a place, it's really hard to get them to move and be more productive again. But so we also asked them about their activity levels, and those were self-reported. So we didn't track their activity levels at all. That would have been pretty difficult within our scope. But our survey respondents, as you can see here, the very first bar was sedentary. So that meant that there was little to no physical activity. And nobody answered that, which we found like that probably wasn't realistic. Maybe they didn't want to admit that they were living sedentary lives, but based on our personal surveys, there's definitely people who would fit that model, but that wasn't reported in the survey. Most people said that they were either lightly active or active, and there were sporadically a few that said highly active. And if you look at quarter 3, there was a spike in people who said that they were active, and the time frame which we distributed our quarter 3 survey was around the winter holidays, so around the new year, and we figured maybe more people decided for their New Year's resolution they would be more active, they would get that gym membership, and so that was why the self-reported activity level for quarter 3 was pretty high for active. And then lastly, for the quarterly online surveys, we asked a question about the mental health promoting items that were in our Work for Wellness newsletters, and we asked them how likely they were This was if they noticed the mental health promoting items, and 76% of them said that they did notice that we were trying to prioritize mental health, and so that's over 3/4. 13% said no, and 11 said they were unsure. And the next thing that we did was improve. So this was one of those things that the family medicine department already had existing. They had 3 boards designated for the Wellness Champion, and when we first started the project, they were chaotic. They were a mess. They were so disorganized. Everything was in black and white. Nothing was very eye-catching or appealing, and these boards are in a very high traffic area in the department. So everyone would have to pass these boards on their way to the break room or on the way to the restroom, but nobody was really interacting with them. And we could definitely see why. It was very chaotic. And so Elizabeth Huffman, our first wellness champion that we worked with, asked us to manage them and make them look more appealing, make them have something that would incentivize people to interact with the boards. And so one of the boards that we had was an Eat Smart board, and that focused on diet. I don't have pictures for the other 2 boards, but we also had a Get Movin' board for fitness, and then a mental health reducing stress board. And so our Eat Smart board, we had, as you can see, they're healthy alternatives, so things like replacing white bread with wheat or using avocado instead of butter on your toast and things like that. And then we also had nutrition news, which was when every month we would print out a topic that we think was important, such as this one here, I believe, was whether or not vitamins and supplements were actually healthy for you. And we would have a push pin poll there. And so after reading the article, employees could answer questions, such as for this one is, are you still going to continue to use vitamins after reading this article? And that was a way to showcase whether or not people were actually reading, stopping to look at the board, and if they wanted to participate in these new implementations that we were doing. And lastly, for the Eat Smart board, we had recipes. So before, the boards had recipes as well, but they were all in black and white. They were printed out into really thick pamphlets, or packets, I mean, and they were just kind of pinned to the board. And we found ones that were from 2009. We found some that were from 2007 that were still untouched. They had 20 packets on there. Nobody ever looked at them. And so we decided to kind of use what our grandmas taught us, which were basically those recipe cards that you might have seen in your kitchen growing up. My grandma has a ton of them in a book and in a photo book. And so what we did was we printed out pictures of the recipes in color, because they definitely look more appetizing. And we would have 2 entrees and usually 1 dessert. And we would again find recipes that didn't have that many ingredients, that were easy to prep and cook, that didn't take much time, and we would paste them onto note cards front and back and then leave them in those filers that you see there. And what we would do is we would come in every Saturday and count how many of those cards were left. So then from there we could determine how many people were taking them, how many people were utilizing them. And we also put Mayo's food pyramid on there. And it was pretty similar for our other two boards, something news related, and then informational things like in the next slide here, how to do a burpee, or which is an exercise that you don't need any equipment for, but that works your entire body. Things like how to prevent carpal tunnel at work, since you're sitting there typing away all day. Here was a recipe for an energizing pre-workout snack. This was a power ball, as they call it. And other topics such as how to improve your mood while you're at work. So if something stressful happens at work, how could you improve your mood there? And oh, yep, the vitamin supplements thing, are they healthy or is it kind of misleading? So these were the things that we had introduced to the bulletin boards. And go to the next slide, please. So to measure the, oh, I'm sorry. Yep, to measure the interactions with our bulletin, we had, like I said, we measured their popularity by how many cards were taken each week. We rotated those recipes pretty much every 3 weeks. As long as they were there, we'd keep them there. If they ran out of note cards, then that's when we know we should go in and replace them. And we saw that the most popular recipes were the desserts. People really liked the desserts, especially if it had chocolate in the name or looked like chocolate. They really liked that. And even though from feedback from the personal interviews that we conducted, people asked for vegan options or vegetarian options, whenever we did place those options on the board, those were the least popular options. Nobody touched them. People would take a few, but mostly vegetarian, vegan options were not popular. And other recipes that were popular were recipes that could be done for the whole family, so meals for the family, which made sense considering most healthcare workers there had families. And then for our nutrition news, for our push-pin polls, usually by the end of the month, we saw that at least 10 to 20 people were interacting with it, which is a majority of the department that we were studying. And that told us that yes, these boards are in a place that people will see them, and people are interested in interacting with them. Okay, next, please. So in conclusion, based on what we did with the newsletters and what we did with the bulletin boards, my group found that the employees are utilizing the resources that we were giving them, and they, more importantly, are making an effort to improve their health, particularly their mental health. And whether that's by reading the newsletters, whether that's by stopping at the board, they do care about their health. They might just not have had the opportunity to focus on it at work. And so for future improvements, since we still are working with the Wellness Champions on developing these projects further, we're thinking about how we can increase employee physical activity, because that was one of the concepts that I wouldn't say failed to promote, but it was less liked, I would say. And also how to offer incentives for survey respondents. We had online surveys. Maybe people would better consider paper surveys, or maybe if we had something like chocolate, since they really like chocolate, maybe we had a bowl of chocolate for every survey that you take. You could grab one, even though that's kind of counterproductive to the diet argument. But ways that we'd get bigger sample size for our surveys would be very helpful in future directions. And then also more methods for effective encouragement. So that goes back to the culture of health awareness. We wanted the employees to talk to each other about their diet and exercise, to have it be a comfortable, safe setting where they want to talk about their health and not just the patient's health. And also data collection. We had a very small group of about 3 students, and so that was difficult for us to come in every week on a Saturday morning to collect all of our data. And then also we didn't have quite the number of resources that we could have used as far as analyzing our data. And so in the future, we'll look at how to improve on our data collection. Great, and yeah. Done.
Perfect. Thank you. So as you can see, we have a variety of projects, some qualitative and some quantitative, which is pretty neat. And then in addition, our leaders of the organization have been able to kind of go out into the community and spread awareness of what we're doing and show that us little undergraduate students can have an impact in the healthcare setting, which is pretty cool. And so this is a recent picture of us in November at the Family Medicine Forum for Mayo Clinic. So we had 2 posters there from our organization, one just on the patient shadowing and prescription refill staff projects, and then another poster on the wellness champion. As you can see there, both have Dr. John Bachman, our advisor, in there. So it was a really neat opportunity for our students to go and see what other types of quality improvement projects are going on, and we got to network with different health professionals, which was really cool as well. And so we hope to do more of that in the future.
All right, so as you've seen, some of the projects and kind of our commitment to improving patient and provider experience. And we are undergraduate students, but we do have the ability to contribute our time, energy, ideas, and collaborative efforts towards improvement. And we will continue to continue building up our chapter and doing more projects to continue this commitment.
And lastly, we'd have some acknowledgments. We'd like to thank all of our students for their dedication to all the projects, their commitment to our group. We'd like to thank the Mayo patients and providers for participating in our projects, allowing us to work with them, specifically our Mayo liaison, Dr. Bachman. And then we'd like to thank our faculty advisor, Dr. Rachel Olson. She helped us tremendously throughout the semester with our posters and even this presentation. She was with us every step of the way, making sure we were on track. So we couldn't have done this without her, definitely.
And yes, and thank you for coming and listening. So any questions from the audience?
Why are healthcare